So the question comes on where we're placing these leads on the person. All right. So the way I remember it from nursing school, and I still have to say in my head every time I place these on somebody, is white is right. That is, the white electrode is going to the right side of the patient. Snow over grass. So that is, the white electrode is up high, green electrode is down low. Then you have the two remaining, which is the black and red, and that's going to be smoke over fire. Okay, so black and then red. Uh, if they don't have colors on them, they will also often have the RA for right arm or LA for left arm written on them. Sometimes colors get messed up, especially with the 12 leads. And where they're placed will depend if you're doing a 12 lead or if you're doing telemetry monitoring. So if you're doing a 12 lead, you're going to want these placed preferably on the forearms. You can do the upper arms as well. It used to be advised not to put them over tops of bony prominences. The reason for that is you can get some acoustics if they were to bang up against something, but this is generally not an issue. So it's okay to put some over bones. Uh, the other thing is when we're doing telemetry monitoring, okay, if we're on the floor, there's a space right here where the deltoid kind of meets the pectoris, right up here about the clavicular area. That area where there's minimal movement is where you're going to place that lead, okay, for the arm leads. If you place them too far in, you get this very small Einthoven's triangle. It's going to give you a weird signal. It can throw things out of whack. If you place it too far out, you'll get a lot of artifact as they move around their arms. So that clavicular area, kind of far up over there, is the best place to place the arm leads. The left leg lead needs to be below the diaphragm and then to their left side. Reason for this is we remember Einthoven's triangle. Lead 1 goes across here. Lead 2 is the only one that actually goes across their whole chest. You know, if you were to wear like a sash or a bandolier or something. So that one is useful because if there's any differences in lead 2, because it's coming across this way, right, it can be used to determine their respiratory rate. So that's the lead that's used for respiratory rate whenever you have them hooked up on tele. The last one down here is the green electrode. Okay, for all intents and purposes, it does not matter where you place this one. It's used to create AVF, that augmented vector foot, augmented vector right. You don't even need it. If you don't have it, you want to have those augmented vectors. So you'd have 3 leads instead of the 6 that you'd have with the AVF FVR. But this one is just help for balancing out that signal. Okay, so you could place this thing on their leg is the preferred way just because it makes things uniform and it makes it look pretty. You could place this on their upper leg while these are down here. You could place it on their ear. You could put it on their forehead. You could get 2 of them and make little googly eyes on your patient. It really does not matter where this one goes. Okay. As well with the limb leads for the left and right arm, make sure that they're at the same level. If you have one up over here and one over here, that's again going to throw off that triangle we were talking about. That's going to throw out the signal. So where the limb leads, you have a little bit of flexibility as to where you place them. Precordial leads, if you're doing a 12 lead or 14 lead, 16 lead, however many lead EKG you're doing at that point, these are the ones that really matter with the placement, and they're the most commonly misplaced. Okay. The way I always teach this is evens first, then your odds. This will get you the best placement. It's the easiest way to remember, and your odds just kind of fill in the blanks. Okay. So V2 is the first one to be placed, and V2 is to be placed at the 4th, okay, intercostal space, and that's going to be on the left sternal border. Okay. So V2, 4th intercostal space, left sternal border. V4, okay, is going to be placed in the 5th intercostal space, and it's going to be mid-clavicular. Mid-clavicular line, okay. So see we have our clavicle, and just draw that straight down. And then finally V6, what you do is just feel that intercostal space up and around because it is also the 5th ICS, and it is the mid-axillary line. Okay, so the way to place these, okay, we'll do it. You can find the PMI, or the point of maximal impulse, usually right about the just below the nipple, and that's generally speaking, where V4 is going to go. You can also feel for uh, the manubrium here. That'll get you your second intercostal, go 2 down. That gets your V2 on the sternal border. And then go 1 ICS down from there and place your V4. V6, you want to be mid-axillary. Commonly, people will place this very much at the anterior axillary or not even, below the axillary line at all. So once you place those two, V5 very simply goes between V6 and V4. V3 very simply goes between V2 and V4. And V1 is just the opposite side of the sternum from V2. Okay. Uh, it was an old issue, and it still occurs pretty often, where V1, V2 will be placed too high up on the patient. It was old teaching for some reason, or maybe an old myth, that V1, V2 are supposed to be in the second intercostal space. I'm not entirely sure where that started. I don't think anybody knows exactly how or why that started, but it's simply not true, and it'll get you a bad reading on the EKG. As well, if V5, V6 are not far enough over, you'll see later when we do 12-lead interpretation how that can throw things off, and again, it can cause missed diagnoses or poor interpretations of the EKG. All right, so we've placed our electrodes onto the patient. So how do we start turning that into our EKG, right? So whenever we're talking about leads, okay, we have a couple different kinds. So the very first ones we're going to talk about are the bipolar limb leads. Bipolar limb leads. And a bipolar limb lead, when you hear that, should be thinking of a negative and a positive. So what we're going to do is we're going to turn one of these electrodes into a negative and another into a positive. And we're just going to connect those together, just like, connect the dots when you're younger. So for this one, the first one, the right arm is going to be a negative, the left arm will be a positive, and we just connect these two together. And this here is going to be lead 1. The next one we'll do, okay, is going to be the right arm is going to be negative, the left arm will be positive, and we'll connect the right arm to the left leg. This is going to be lead 2. Finally, we connect the left arm to the left leg, like so, where the left arm is negative, left leg is positive, and this is lead 3. Now, for the right leg electrode, as we said, it doesn't really matter. It's used to do an equation that's going to help us average these portions together. So while our bipolar limb leads are going to be leads 1, 2, and 3, we're able to use these and adding this fourth electrode down here, okay, to create a augmented vector. So these are going to be our augmented limb leads, or augmented unipolar leads. And what they're going to do, so for the first one here, is going to average the right arm and the left arm together, okay? And it's going to subtract the left leg from it, and it's going to treat the left leg as our positive, okay? And what we've done when we do that is we'll be able to create kind of like a negative up around here, right? And that's going to create one that's perpendicular to lead 1, okay? So this first one is going to be called the augmented vector of the foot. Okay. Augmented vector foot, or AVF. And you just do the same thing going up and around here. So the left arm would get a positive, and it would be perpendicular to 2, right? And that one's going to be the augmented vector of the left arm, or from the left. We do the other one up over here. It's going to be AVR, and it's going to be perpendicular to lead 3. Okay, so our augmented limb leads are going to be AVF, AVR, AVL. Finally, the last ones that we could place on here, okay, that we talked about placing on the chest, are our unipolar precordial leads. And when you hear unipolar, it means that there's only a positive. The actual negative for these augmented leads and the unipolar, the precordial leads, are being computed, okay, and that's coming from our limb leads. So there's not a true electrode on here that's being negative. it's something that's being kind of inferred. Our unipolar or precordial leads are going to be all those V leads. So V1, V2, V3, etc. down the line. Okay. So now if we look at this, we're going to take this as something you've probably seen before, and it was probably confusing if you didn't know what was going into it. And that here is Eindhoven's triangle. Eindhoven's triangle. Okay. And this is the kind of important thing that we've been leaning to this whole time. So that is connecting those leads, just like we said. We have the right arm, the left leg. We've created those bipolar limb leads 1, 2, and 3 on here. Okay? And it should, in theory, create this kind of equilateral triangle. Now, if the left arm was placed at a different level, say up here, we don't have that equilateral triangle anymore, or if the left leg was placed on the right leg, it's going to offset, etc. So that's why the placement of that, even though there's a little bit of leeway, they need to be equal. Because we want to create something that looks like this. Now, the important thing whenever we're doing the precordial leads, and whenever we're trying to translate this in the actual how the leads are, working, is to understand another important part here. It's called Wilson's central terminal. Okay, so let me write that over here to the side. Wilson's central terminal. Okay, or WCT. There's also Goldberger's central terminal. They're both talking about different ways of finding the same thing. And all that is if we add leads 2, 3 all together here, and we find the point of zero potential. Okay. In theory, that should be the dead center of this triangle. Okay, so that middle portion is Wilson's central terminal. That's going to be the middle part of this EKG. And this might, again, fluctuate if the leads are misplaced or if something else is going on with the electrical system. But the important part is that this is going to be the middle part, and this is where the leads are drawing off of. So even though lead 1, you're connecting the shoulders is going this way, the actual way it's going to be reading is going to be coming from this. Okay, Wilson's central terminal here. Just as lead 2, we're going to superimpose it this way, and it's going to be coming like so. Lead 3 gets superimposed, and it's going to be going like so. So these angles, even though they look outside the heart, are actually coming inside the heart at some point. The same thing for those precordial leads. They all start from Wilson's central terminal here. And this is an important part when we're talking about ischemia and knowing what part of the heart is being affected with these leads. So as we get into this, okay, we're going to draw Wilson's central terminal. So kind of right about in here. And this, again, it moves and it fluctuates depending on a bunch of factors. But for the sake of this, we're going to place it right here. And what we're going to do is we're going to start imposing these leads onto this heart. Okay, so lead 1 went pretty much directly straight like this. Okay. So whenever it's coming and looking at this side of the wall. So there is lead 1. All right. Lead 2, as we said, had its angle. It comes down kind of like so. It's coming like this. And there is lead 2. Lead 3 had an angle that was going this way. So if we impose that way, we'll get right here. This is lead 3. And now it's important to remember too that the observing electrode, that positive electrode, is what determines which way this is coming from, right? So even though the negative is up over here, the part that we're caring about is as if it was up over here and the positive is on this side. Because that's the way it's going to be looking at the heart. So we're going to add in now those augmented leads. So remember, AVF was directly perpendicular to 1. Okay. So AVF. Then we had AVL was kind of up this way, and it's perpendicular to 2. AVL. And then we had AVR, which is the odd one out. It's the only one that's going to look up over to this other direction. Okay. That is AVR. Now, when we add in the precordials, make things look a little bit wonky on this view. But we'll step back and look at this first. Okay, so these bottom three, 2, 3, and AVF, okay, these form what are called our inferior leads. So lead 3 is kind of looking at this portion of the heart here. Lead 2 is looking at this bottom portion of the heart up over here. And AVF is looking at this area up through here. And this whole area is the inferior wall, or the inferior portion of the heart. So inferior leads are 2, 3, AVF. Okay. Then if we look at lead 1 and AVL over here, lead 1 has this side of the wall, and then AVL has kind of up over here. And these are called the lateral leads, or you may call the high lateral leads. Okay. So we'll do high here. That's be 1 AVL. And that infers that we have some low lateral leads. And that's going to come from our precordial leads. So if you imagine these coming now towards us, okay, the first two are going to come off of here, kind of towards us like so, and it's going to be V1 and V2. And they're going to look at this little septal area right here, okay. So those are going to be our septal leads. That is V1 and V2. The next ones that come after that, okay, they're going to come pretty much directly towards us at this point, and they're going to look at the whole front portion of the heart, okay, or the anterior wall. And that's going to be V3 and V4. So our anterior leads are V3, V4. Finally, we have those other leads that are come off to the side here. So they're going this way, right? Remember, it was kind of important for V4 is about at the apex, and these are going to be off to the side, especially V6 and V5. And they're looking at this portion of the heart here, or the low lateral area. So V5 and V6. Okay. So if you understand this portion, if you've ever heard somebody's having a lateral MI, somebody's having an inferior infarct, this is what we're talking about, okay? So this is your way of drawing this out and visualizing exactly what part of the heart is being affected, or what part of the heart we're seeing whenever we're looking at the EKGs later. As far as AVR, it's kind of a weird one out. It looks, you can say the right side, but generally it's going to be used for like general ischemia.